Good morning, everyone. Welcome to ISG Masterclass. Now we are doing a series on GI cancers. Last week we had a discussion on carcinoma gallbladder, and this was a panel discussion, and we discussed very relevant issues required in the management of carcinoma gallbladder. We are coming again with today with yet another topic that is on cholangiocarcinoma, and we know treating cholangiocarcinoma is a bit tricky, and it requires a good amount of coordination between many specialists. It requires gastroenterologists, it requires surgeons, it requires help of a radiologist, it requires a medical oncologist. So today we will have a panel discussion on cholangiocarcinoma, and for which we have a very esteemed panelist, I would say a dream panelist for ISG. This panel is being moderated by Dr. Sandeep Lakhtakia. Sandeep Lakhtakia, we all know that he's a director of endoscopy and endoscopic ultrasound at Asian Institute of Gastroenterology in Hyderabad. He's also the Secretary General of Society of Gastrointestinal Endoscopy of India, and he's also Vice Chairman of International Committee of ASGE. Thank you, Sandeep, for taking all the time to moderate this session. Now we have on the panel, we have again very esteemed Dr. P. Jagannath, and I think his country knows him, and he's so well known world over. Presently, he is chairman of Department of Surgical Oncology at Leelavati Hospital in Mumbai, and he's also had been the past president of International Association of Hepatobiliary Pancreatic Surgery. Now we have on the panel Dr. Anant Ramaswamy. Dr. Anant Ramaswamy is an associate professor of medical oncology at Tata Memorial Center in Mumbai, and his specialty is medical oncology. We have from radiology Dr. Sivanand Gamnagati. Sivanand is a professor of radiology at All India Institute of Medical Sciences in New Delhi, and he is very esteemed interventional radiologist. And we have yet another esteemed person on the panel, Dr. Rajesh Puri. Dr. Rajesh Puri is a gastroenterologist. He's a director of interventional radiology at the Department of Gastrointestinal Sciences at Medanta Hospitals in Gurgaon. Again, very well known. So with this esteemed panel, we are going to have a very useful discussion which are relevant for a diagnosis and treatment of cholangiocarcinoma. So welcome everyone to this panel discussion. Now we hand over to Dr. Saraswat for a welcome remarks, and then we go over to panel discussion. Dr. Saraswat, please.
Thank you very much, Dr. Govind. Good morning to all participants and to all the panelists. It's a great pleasure to welcome you in this ongoing series of panel discussions in GI oncology that the ISG has started during masterclasses. This is our third session after GI lymphomas and gallbladder cancer, which happened last week. And we now will be taking up the issue of cholangiocarcinoma. There's a clear-cut north-south divide in the cholangiocarcinoma, gallbladder carcinoma belts. Not where we don't see them in all parts of the country, but somehow cholangiocarcinoma tends to be the dominant biliary cancer in the southern and western parts of our country. And cholangiocarcinoma is particularly challenging because a lot of newer modalities and not just advances in surgeries, but newer endoscopic techniques that allow for good, effective, long-term palliation of this tumor are now available. So it makes it all the more demanding and challenging for the treating team to get their decision-making and to get their management spot on so that the best outcome is available to the patient. Dr. Govind has already introduced all the eminent panelists to you. Dr. Sandeep Lakhtakia, who will be moderating this session and anchoring it, is well known to all of us. Professor Jagannath is the doyen of HPB surgery, not only in our country, but is a well-known surgeon globally. And Dr. Rajesh Puri is one of the best-known interventional radiologists in the northern part of our country. Dr. Anant and Dr. Shivanand are very eminent workers in their own field on medical oncology. Dr. Shivanand is one of the best known intervention radiologists also. So I agree entirely with Govind that we could not have got a better team of together for addressing these issues on cholangiocarcinoma. So I think I look forward to a very interesting hour, and I request Dr. Sandeep to get the ball rolling on the panel discussion. Thank you.
Thank you, sir. Good morning, everybody. So we have expert panel, as Dr. Saraswat and Govind have said, and we have set a series of questions which will be addressed to the surgeon, Dr. Jagannath, or intervention endoscopist, Dr. Rajesh Puri, oncologist, Dr. Ramaswamy, and radiologist with interventions, Dr. Shivanand Pat. So let me set the ball rolling. I would like to highlight in the beginning itself that cholangiocarcinoma is different from gallbladder cancer. Okay, and then, so before we go further, let's understand the radiological anatomy of cholangiocarcinomas, how each one is different from other. And for that, may I request Dr. Shivanand to speak on how do you classify radiologically the different cancers based on anatomy? What do you mean by bismuth classification? And when would you actually consider imaging different from a conventional CT, that is a PET CT or MRCP, in different phases of the disease? Dr. Shivanand, can you take on from here the radiological aspects of the diagnosis of cholangiocarcinoma?
Okay, sir. Good afternoon, everyone. So let us start the session with the classification and the role of imaging. So the first is let us see the anatomical classification of the cholangiocarcinoma based upon the location. They are broadly divided into intrahepatic and extrahepatic cholangiocarcinomas. The intrahepatic cholangiocarcinoma, they are popularly described as a peripheral cholangiocarcinoma. And whereas the extrahepatic cholangiocarcinoma, they are divided into perihilar or a proximal cholangiocarcinoma or a distal cholangiocarcinoma. All these are based upon the location. Coming to the peripheral or the intrahepatic cholangiocarcinoma, it accounts for 10 to 20% of all the cholangiocarcinoma. It usually presents as an intrahepatic mass. Cirrhosis is not a feature in case of cholangiocarcinoma as contrary to its hepatocellular carcinoma. These tumors are usually treated by hepatectomy. Whereas perihilar is the most common of all the cholangiocarcinoma, accounts for 50 to 60%, typically involves a biliary confluence, and they are treated either by resection or a hepatectomy. And coming to the distal, they are account for 20 to 30%, and they are usually treated by pancreaticoduodenectomy. So this is the anatomical classification. There's another form of classification, what is called as a morphological classification based upon the gross pathological specimen. Amongst them is the mass forming is typically presents as an intrahepatic mass, accounts for 20% of all the cholangiocarcinomas. Whereas the commonest variety of the cholangiocarcinoma morphologically is the periductal infiltrating type, which accounts for 75 to 78%. Whereas intraductal type may be seen in the intrahepatic, may involve the intrahepatic biliary radicals or in the common duct, accounts for 2 to 5%. So this is the pathological classification. Let us see these things, how they look on imaging. The intrahepatic cholangiocarcinoma, they appear presents as a mass, may be associated with a capsular retraction. In the arterial phase, it shows a typically peripheral rim enhancement. In the delayed phase, it shows a filling in because of serous nature. And in the delayed phase or hepatobiliary phase, it will show a peripheral washout, which is called as a rim sign. So peripheral rim enhancement and filling in and a peripheral washout is a typical feature of intrahepatic cholangiocarcinoma. However, the commonest garden variety of Claskin tumor or a hilar cholangio, it presents as an infiltrative mass, enhancing infiltrative mass starting at the hilum, and it may extend along the intrahepatic biliary radicals. So this is the commonest variety of cholangiocarcinoma. The third one is the very rare one is the intraductal. It presents as a intraluminal polypedal mass which causes distension of the CBD. As in this case, the CBD is distended and it is filled with an enhancing soft tissue mass. The popular classification, which is known among almost all the group of persons, is the Bismuth classification. It is based upon the longitudinal extent of the tumor. So before we interpret how to interpret this Bismuth classification, you have to know the anatomy very well. For that, you have to look at the projectional MRCP image. So this is the projectional MRCP image. So let us see the anatomy first. This is the anterior sectoral duct of the right hepatic duct, posterior sectoral duct, which is relatively horizontal. They together form the right hepatic duct, which is very short in length. On the left side, we have a segment 2 duct, which is superior, and the segment 3 duct is the inferior one. Together form a left hepatic duct. And the right and left hepatic duct together form a common hepatic duct. This common hepatic duct beyond the cystic duct is called as a common duct or a CBD. So this is the normal anatomy. So there are two terms you should be aware of it. One is the primary confluence. Primary confluence is nothing but the where the right hepatic duct and the left hepatic join. That point is called as a primary confluence. And the secondary confluence is that area where the right side anterior sectoral duct and the posterior sectoral duct join. That is called as a secondary confluence on the right side. Where the superior and inferior duct on the left side, they join, which is called as a secondary confluence of the left duct. So this anatomy is very, very important to understand the Bismuth classification. So the type 1 Bismuth classification, which accounts for 2.5%, and it individually involves the proximal CBD, and the primary confluence is patent here. So it does not involve the primary confluence. When the tumor involves a primary confluence, it's called as a type 2. When the tumor extends to involve the right-sided secondary confluence, it is called as type 3A. Similarly, if it extends to involve the secondary confluence on the left side, which is relatively uncommon or less common than the right duct, because right duct is short, which tends to involve much earlier than on the left side. When the secondary confluence on the both sides are involved, it is called as type 4. So these are the various types of Bismuth classification based upon the longitudinal extent. So that is all about the classification, anatomical, pathological, and the longitudinal extent. Now coming to the role of imaging, there are two roles. One is for diagnosis and the characterization. So for intrahepatic cholangiocarcinoma, it has to be differentiated from HCC or it is maybe a mixed variety of cholangiohepatocellular carcinoma. It can be done either by multiphasic CT or MR. Coming to the extrahepatic cholangiocarcinoma, it has to be differentiated from the benign stricture, which is best assessed by the multiphasic MR, which is called as a prognosis solving tool for differentiating these two entities. Once we have made a diagnosis of a hilar cholangio, the garden variety of cholangiocarcinoma, we have to define the extent of the disease. So there are two parts to assess the extent of the disease. In fact, three. One is the involvement of the biliary extent. That can be done better by the MRCP image that I have already described. Whereas nodal or vascular involvement, adjacent organ invasion, which can be done either by multiphasic CT or MR. Both are equally good. Whereas the metastatic disease, in case of resectable disease, you want to exclude the metastatic disease, that is ideally done by the PET CT. So these are the role of each modalities. So currently, as per the recommendation, the most widely used modality for local staging is the MDCT, but it has one of the major drawback. It underestimates the longitudinal extent of the tumor. To overcome that, it is always the MDCT is coupled with the MRCP to look for the longitudinal extent of the tumor. So two modalities will give the entire local extent of the disease. And also important role of MRI is to differentiate the benign stricture from the malignant stricture. So I will not go into a detail. So that is a different topic altogether. And PET CT gives a whole body imaging. It's very sensitive to detect the metastasis and also lymph nodal metastasis. And moreover, it is also used for detecting local recurrence after surgery. So for assessing the local staging, the vascular involvement, adjacent organ invasion, lymph node metastasis, you can go for either MDCT or MRCP. But MDCT has a better understanding for the surgeons. So MDCT, and it is more economical also. Whereas longitudinal extent, it is better assessed by the MRCP. So these two together gives a complete information. So you have to understand the unresectable criteria. The unresectable criteria are if there is involvement of the secondary confluence on either side, if there is involvement of main hepatic artery, main portal vein, metastatic disease, bilateral invasion of the hepatic artery or a portal vein, one side hepatic artery or a contralateral portal vein, or if the future liver is completely atrophic. So then even it involves the right lobe and the left lobe is completely atrophic, then again it becomes a inoperable. So these are the criteria for unresectability and the role of imaging and the classification. So now the next speaker will take over. So I will stop it here.
Thank you, Shivanand, for explaining very nicely the radiological anatomy, how to diagnose and find out whether the tumor looks to be operable or not. We'll move to the second question, which I address to Dr. Rajesh Puri. How would you, Rajesh, how would you confirm the diagnosis in a suspect case? A person comes to you with jaundice and has some biliary obstruction without any other evidence of stone disease or a mass. How would you move forward from here? Rajesh, can you hear me? Hello?
Can you hear me now?
Yes.
Yeah, Sandeep, is a very relevant question, especially in the perihilar cholangiocarcinoma. Can you shift the slide, Sandeep, to the next? So, because most of the time, either the surgical colleague or the oncological colleague, they require a tissue diagnosis. But I think in the cholangiocarcinoma, because of the desmoplastic reaction and the site of the lesion and the complexity of the lesion, it is very difficult to give the tissue diagnosis. So whenever you manage the patient of perihilar malignancies, it is important you should have a multidisciplinary approach. The most important, all patients
can you increase your volume? Your volume is not, if you have kept your volume at the maximum.
Am I audible?
Yes, now.
Yeah. So all cases of hilar blocks don't require tissue diagnosis. An elegant study, it is from the All India Institute of Medical Science. I think if you look at this study, they have taken the account the biochemical parameter, that is bilirubin level and CA19-9. As spoken by my previous speaker, if you look at the characteristic CT finding, as well as MRI finding, and if you take the biochemical and the CT MRI finding with the pretest probability of the disease. The meaning of pretest probability of disease is if a 60-year-old male comes who has loss of weight along with the hyperbilirubinemia, in those situations, I think probability of malignancy is high. And I think if the patient is operable on the MDCT along with the MRCP, you can directly shift the patient for the surgical intervention if the patient is operable. But yes, if the diagnosis is in the doubt and the multidisciplinary teams feels that this patient requires tissue diagnosis, then we have got a number of the tests which can be done, like ERCP, which is the standard technique. You can do the ERCP guided cytological sampling. You can do the conventional intraductal biopsies, and you can do the FISH also. We can do EUS and EUS-FNA, spyglass cholangioscopy directed biopsy, and the visual impression on the spyglass, and the immunohistochemistry to rule out the IgG4. That is important. Next. So if you look at the cholangiocarcinoma or the hilar block, the role of endoscopic ultrasound in literature is not very well defined. But I personally feel, and I think Sandeep will be agree because he's also a master of endoscopic ultrasound. If you look at the rest of the tests, that is ERCP, cholangioscopy, they are more invasive. They lead to the chances of cholangitis. You require the drainage of the ducts. Endoscopic ultrasound is a modality. Can we keep on the slide on the previous one, Sandeep? Yes. Endoscopic ultrasound, you can do the periductal or celiac or peripancreatic lymph node FNA, and you can give the morphologically what kind of structure is. And if you look at the role of EUS in the hilar cholangiocarcinoma, these are the 5 studies, and that shows a very high sensitivity and specificity of endoscopic ultrasound for the hilar blocks. and in comparison to the CT and MRI. And this is the impact of EUS in the clinical management of cholangiocarcinoma. And if you look at from 1/3 to half of the cases, you can change the management, you can find out the benign disease, you can pick up the metastatic disease, or surgery based on the basis of EUS can be modified and the diagnosis other than cholangiocarcinoma can be proved. Next. If patient is going for the ERCP, then yes, you can do the intraductal biopsies, and along that you can do the intraductal endoscopic ultrasound. And the advantage of intraductal endoscopic ultrasound is it is very good for the T staging of the hilar cholangiocarcinoma, as well as longitudinal extent of the cholangiocarcinoma can be given by better, as well as hepatic artery and the focal vein involvement can be very well given by the intraductal ultrasound. Next. When we talk about the role of ERCP, I think ERCP should only be done if the multidisciplinary team feel that these patients require a biliary decompression along with the diagnosis, then you can do the breast cytology. The sensitivity is very poor, 30 to 60%. Intraductal biopsy can be done, which increases the sensitivity, and combination of the breast cytology and intraductal biopsy increases the yield up to 60%. Next. And if you apply the fish, then the sensitivity of specificity of the cytology increases. Next. Cholangioscopy, I think this is the new dimension, and cholangioscopy has an advantage. Visual appearance of the stricture can give the idea about does this patient has a malignancy or not. If there is a mass, if there's a tortuous vessel, if there's a papillary font or the villus projection, or you find an intraductal nodule, then on the visual impression with a fairly high sensitivity, you can say this patient has got a malignancy. This is the new classification which is published in 2020, that is FV classification. F means on the basis of flat pattern, granular, papillary. So as the F increases, similarly as the V increases, meaning that if there is a nodular pattern, irregular, dilated, tortuous vessel, on morphologically, on visual impression, you can say this patient has a malignant biliary stricture. You can do the cholangioscopy guided biopsies also. Next. So cholangioscopy guided biopsy, this is the meta-analysis of 10 studies, more than 450 patients, which has a specificity of 97% with the sensitivity of 66%. Next. Thank you.
Can you hear me now? Yes.
Yeah, I can hear you.
Okay. Thank you, Rajesh, for elaborating on way to diagnose suspected cholangiocarcinoma.
Important message is, Sandeep, all cases does not require tissue diagnosis. There should be a multidisciplinary approach. If the surgical colleague feel this patient is operable, you don't have to go for the tissue diagnosis. If the multidisciplinary team feel that the patient requires tissue diagnosis, in that case, you can do various techniques and you can do the diagnosis.
Okay, okay. So with that, may I address the next question to our surgical expert, Dr. Jagannath, on what would you, or how does a surgeon want the gastroenterologist to look at these diagnoses? Would you want to have evaluation? What are the evaluation parameters that you want before considering a patient for resection? And would you want a preoperative histology? Because that's not very easy to obtain all the time, as Rajesh has rightly said. How do you approach that?
Thank you, Sandeep. I think Govind and Dr. Saraswat and ISG, you deserve huge compliments for bringing a surgeon on board, because I think in this country, we have practiced gastroenterology, oncology, and surgery in silos, and that has certainly not benefited the patient. So I think this is a great series. I'm so happy to be a part of it and tell about what the surgeons really, how we can work as a team, and that's the most important thing. The first question is that what does a surgeon want a gastroenterologist to look for? Gastroenterologist is the first medical expert patient is going to meet, and you do not be a referral point for an oncologist or surgeon. You need to understand a few things which will make things much better for the patient in the future management. Sandeep, next. Now, I just want to put a little bit of anatomy in perspective so that you understand what the surgeon really wants. If you look at the upper picture with, that's a hilum. It's a very small part of the entire liver. We are not talking about intrahepatic cholangitis here now, nor the ductal tumors distally. We are only in the perihilar region in the cholangiocarcinoma. Look at the portal vein. Portal vein confluence lies just behind the ductal bifurcation. The second thing is that you see how the hepatic artery, look at the right hepatic artery. The right hepatic artery crosses behind the bile duct and goes on to the right side. Very interesting information also, the left hepatic artery, so, particularly to segment 4, takes off earlier and then doesn't hit the hilum and goes on to the round ligament fissure. Very important points. And the segment 4 vessel, which is seen there, goes close to the hilum. So this is a very important anatomical information. When you come to the lower picture, you find out what is the posterior border of the hilum. The posterior border, the posterior surface of the hilum rests on the caudate lobe. Very important for us because caudate lobe ducts are one of the earliest ducts to be involved in hilar cholangiocarcinoma, both from the right duct or the left duct. Small pricks go into the caudate lobe for drainage. So, and the portal vein branches, typically the caudate lobe is supplied separately from the right and left portal veins. This is very important for the surgeons to understand, and this is important for the gastroenterologists to look for. Sandeep, next. Now, it's a very small area. So any error in this area, it becomes extremely difficult because there is no going back. So it's, all of us have to understand the anatomy very, very clearly to plan the right kind of a management. Next. Now, this is the schematic part of the liver. I just want to tell the gastroenterologist that fundamentally look at liver as 3 sectors. Left lobe of the liver is the left sector. The right is divided into the anterior sector is segment 8 and segment 5 there, and the posterior sector, which is posterior. So 3 sectors. So fundamentally, your resection has to involve just 3 sectors. It is one part of one or part of the other, and combined with that, that's it. We don't have to go beyond this as far as the anatomy is concerned. Next, please. Now, what are the staging? The staging is extremely critical. Only one thing I want, one single message, and I can stop here. The stage before intervention. This is very, very important. Stage first and then the intervene next. Now, how do you stage these tumors? There are 3 elements of staging of tumors. And Sivananda has given a good talk, very informative. First thing is the bile duct involvement, the longitudinal and radial involvement of the bile duct. The second is what is the vascular involvement. And the third, is there any local regional or distant metastatic spread? These are the 3 informations which you need. The biliary involvement or the ductal involvement, what the surgeon is interested is in the proximal extent of the involvement, not the distal. Distal is what you see below. No, we are not interested in that. We are interested in how far intrahepatic is the ductal involvement. Is it going on one side or the other side? So this is very important. The second thing is portal vein involvement. Is it a confluence? Is it going on the right side or the left side? And the arterial involvement. As I told you in the anatomy picture, the right hepatic artery crosses just behind the hilum. And it's the first vessel to be hit. Very important for us to understand the right hepatic artery involvement. Next. Now, this is, I don't want you to be confused by this complex biliary anatomy by Nimura. But look at this. If you see the 8C and 4B ducts on the supine position, they are next to each other. So an MRCP very easily can confuse this ductal system. So that's why you need to rotate the patient and see in the right lateral position where the 8C now moves far away from the 4B because though they look very close to each other in supine position, they move away from each other. So rotational imaging is very, very critical to understand the ductal anatomy because 4 belongs to the left side and the 8 belongs to the right side. So that as simple as that. Next. Now, to make it simple, as Shivananda said, stick to Bismuth classification. What is important is what is the intrahepatic extent. I'm not even talking about type 1. Type 1 is subhepatic. It's a kid stuff. Type 2 and type 3 onwards need hepatic resection. And to determine which part of the liver has to be resected, you need to understand which side of the ductal system is involved. Is it going on more on the right ductal system or the left ductal system? In other words, if the right ductal system is involved up to the second order, second confluence, that means it's a right dominant system. If the left duct, on the other hand, is going on to the segment 4 and the segment 2-3 duct, is a left dominant system. If both are involved, it's a type 4 disease. So this is something which is important for you to understand that this is what the surgeon wants. Next. Now, very small practical points. When you see this MRCP, what do you think? It's a very simple subhilar block, type 1 disease, easily manageable. That's what is your normal feeling. Next. Now, when you do an ERCP, an ERCP suddenly finds, no, it's not a type 1 block, it's a type 3 block, because there's an overlap of the left ductal system on the right ductal system. It looked like a type 1. So this is a typical error which we make when we say next, that a dilated MRCP, just one point on the previous slide, a dilated system, an MRCP, can be misleading. So your cholangiographic evaluation should be on an undilated or decompressed system. So this is point number 1 for MRCP is concerned. So don't go by the first MRCP for your typing of the disease. Next. Now that's the reason why if you do a 3D reconstruction, you can rotate the image. You can actually see the ducts moving away from each other or close to each other. And the overlap can be identified clearly. And then you'll know the biliary ductal involvement. In a bismuth type 1 and type 2, it's fine. You can really accurate. But in bismuth type 3 and 4, there's an underestimation, largely because there can be a dilated ductal system. But as far as I agree with Sivanand that for a ductal involvement, MRCP is the gold standard, or it's a good investigation. But it has to be complemented with CT. This is a tumor where it needs more than one investigation. So a triphasic CT is necessary. Next. For the what? So biliary extent is good, but ERCP certainly does not delineate the proximal extent. So this is one simple message for the gastroenterologist. So don't go on ERCP for ductal involvement. Next. Now the vascular involvement. The vascular involvement, triphasic CT has really replaced the conventional angio. We used to do conventional angios long back, but now no longer. Triphasic CT is good. And this has to be done prior to any kind of a stenting. My real humble plea, if you do a stent, the vital information at the porta hepatis, where I just talked to you, will be obscured by the stent, whether it is plastic or metal. So you lose a very critical information. Do it just before you put in any kind of a stent. Now you see that the right branch of the portal vein, which you can very easily see, if anyone can see this, the main portal vein, the left portal vein, the right branch of portal vein is blocked by the tumor. It can also be seen in the other image. Right branch of portal vein is missing. The left portal vein is filling nicely. So this is an important information. Stenting will block this important information, and particularly the right hepatic artery is very difficult to see after you put a stent. Next. So the arterial involvement when compared to resected specimen is far better on MD-CT along with the PTC than just see. Now the question is always asked that why not have only MRI as an investigation? I think Shivanand will say that most of the MRs are not initially done for a triphasic study. They're just simple MRCP. So I would always have a triphasic CT in addition to an MR. Next. This is one thing which I really want you to carefully see. You find that, oh, when I see it first time, oh, the left ductal system is dilated. No, they're not dilated. It's a lobe has atrophied. That's why the ducts look dilated. But that's an affected lobe. And if you carefully see, there is a clear-cut perfusion difference between the right and left lobe. You can see a line where you can see a perfusion difference in the upper corner image. And that's a perfusion difference. It's very important to detect the crowding, lobar atrophy, and perfusion defects on the portal system. And when you see the portal vein, you find that the left portal vein is missing. And this is a classical example of left portal involvement by the hilar tumor. Next. So this is how we need a good information as far as the initial workup is concerned. I'm sure that's what we want to know. Now for the evaluation for resection is concerned. Evaluation for resection is the next issue. Am I with you?
Yes, please go ahead. Please go ahead. I can hear you.
Yeah. I am seeing can we go down to evaluation of resection? The next question, the slide number 15. Yeah.
Can you see the slide there?
Yeah, I can see the slide now. Okay. Now, how do you evaluate for resection? This is fundamentally, I'll tell you what are resectability, what is non-resectability. This is next. Now I have next.
Is that okay? The slides are, Dr. Jagannath, can you hear me?
No, you go back, please. Now, Eugene Imra, I have to always say that, I've learned a lot from him, but meticulous planning pre-operatively is the only key for success. Next. Now, this is what I'm saying. The ductal anatomy has to be studied in more than one plane because you need a good amount of ductal anatomy. So you might use an anterior oblique projection for ductal anatomy. Next. Now come to the resectability. Resectability is very simple to define. Now, if the bile duct is involved into the first order or even the second order of the ducts, without involvement of the portal vein or hepatic artery, it is resectable. And it is Memorial Sloan Kettering is a very simple classification of saying is T1 resectable. Very simple. No portal vein involvement, ductal involvement to one side, resectable. Next. Now, there is ductal involvement to one side and the portal vein involvement on the same side. So ipsilateral vascular involvement and the ductal involvement resectable. Either it is right or left is fine. Involvement of confluence is also resectable because you can resect the confluence along with the portal vein and reconstruct specifically on the left side. So still resectable. So these are the resectable criteria. So if you assess this, that means this patient will benefit by surgery. Next. Now then comes the functional status of the liver, not just the anatomical status, functional status is very important. All the 3 tumors to get a negative margin will need liver resection. So most important thing we have to assess is that is there a sepsis? Is the patient having cholangitis? Cholangitis is the worst form of sepsis. Fever, chills, a high CRP, you have to immediately intervene. And what is the kind of liver status prior to jaundice? Was he on alcohol? Was he having a fatty liver? Is there cirrhosis? This is very important. And then your imaging person also has to give you a CT volumetry for surgery. Next. Irresectability. Now we know that resectability, the patient factors are, of course, medically not fit, cirrhosis, hepatic duct involvement beyond the secondary biliary radicals on both the sides, or a contralateral vascular involvement, or a distant disease. So if you have a right portal vein involvement and the left ductal system involvement, non-resectable. If you have both side biliary tree involvement like type 4 disease, or non-resectable. Otherwise, most of the tumors can be resected. Distant metastasis, yes, certainly not resectable. So these are the criteria for resectability. I would agree with Rajesh that pre-op histology is not necessary because it's difficult. And not only it's not necessary, they're all blocks of malignant. So many times it can be as sensitivity is maybe high, specificity is high, sensitivity is low, and we need resection irrespective of the histology. If an unusual presentation is there, like a low jaundice and an MRCP shows features of sclerosing cholangitis, do an IgG4 serum, and then we can go on that. But otherwise, I don't insist on histology. We have resected sclerosing tumors, but that's a treatment for sclerosing non-malignant lesions. But that's a treatment for that because they can't be treated with repeated stentings. I discarded CA19 completely, but it's not at all specific, and so the values are so fluctuant in jaundice that is no longer a diagnostic tool, and I would not recommend CA19. One last point on the PET CT, we don't do it routinely because MR gives a lot of information on the nodal stages. If it is showing an N2 nodes, and I want to confirm by any chance, then only I do a PET CT because otherwise I don't do PET CT. The PET triphasic CT, no, it's a misnomer. Sivanan should clarify on that. The triphasic, the machine is only about 16 slice machine, and what we need a good triphasic CT scan is about 160 slice machine. So I would not go with just one investigation. The PET scan is very, very selective. Next.
I think that's the last slide of this talk, this question. Thank you, Dr. Jagannath, for enlightening most of the non-surgical audience in this group about when, how we consider a patient to be operable or not, when not to put a stent, evaluate the anatomy, especially at the hilum, and see whether if it's operable, get the full information before intervening. Talk to your surgeon, know when it is not operable, then you can consider it. Okay, we move on to the next set of questions is drainage of our obstructed biliary system. May I now call back Dr. Jagannath once again? What is your preference? When would you request an endoscopist or radiologist to consider pre-operative drainage? A patient is operable anatomically, but he has deep jaundice more than 15. What would you like to have?
Now, this is an important issue. Though we fought against drainage for the lower CBD tumors, we are pro-biliary drainage for the hilar tumors. The reason is next, that most of these tumors need liver resection. So cholestatic liver is very, very, very dangerous to resect. So what are the questions we are going to ask? When to drain? So clearly it is after the staging and before the liver resection. We need to drain. If there's a cholangitis, drain quickly. Just get a triphasic CT done and then drain quickly because it's very, very, very tough. Now the question is PTBD or EBD, and which side do you drain? Right side or left side? And how do you determine which side to drain? And what's the meaning of lobar atrophy? Next. There's something which you should not do. This is, I put a cross, maybe animation issue, but this is no for anyone. No multiple stents from below. That is out of question. So that is something which is risky and dangerous. Yes, PTBD, yes. If you put a multiple internal stents, small caliber stents, that's really going to be, patient is never going to come for surgery. He'll just suffer in cholangitis and eternally, literally. Next. Now, preoperative PTBD, what's the advantage of PTBD? It optimizes the pre-op preparation. And because once you put in a PTBD catheters, we put it above the tumor, the biliary tree decompresses and you can do a PTBD, PTC cholangiogram again. And the hypertrophy will start happening once you drain the system. Otherwise, it will not happen. So jaundice system has to be drained. And the only problem is PTBD, like the ERCP, like any investigation, needs a good expert hands. PTBD can be risky, can lead to sepsis, can also lead to track implant. So you need a good IR person to a good PTBD, peripheral PTBD, not central PTBD for these tumors. So PTBDs are our preference. Now look at this. This is a classic example. Now EBD, the endoscopic biliary stenting, look at where the stent is. The left lobe and the posterior sector remain undrained because of this stenting, endoscopic stenting. Then there is an anatomical reason for it. Can I have the next click on that? Yeah. If you see the segmental anatomy of the liver, the CBD, common hepatic duct, is in the same straight line as the segment 4 duct. So when you walk, your stent walks in, it just straight away walks into a segment 4 duct. Because the segment, the left duct is at an angle, and because the posterior sector is at an angle, it will not hit the, it is not easy to get into these sectors. It's very difficult. Or at least for me, it is, I find the endoscopist, I think Rajesh can do it maybe, but it's difficult to get in because the walks into the path of least resistance, that is segment 8, leaving the left lobe undrained, and cholangitis will start coming. And I think as a dictum, I think all of you will agree that you do not push the contrast too much as far as your ERCP is concerned. If you push the contrast, it will go into an undrained segment and cholangitis is bound to happen. Next. So I prefer a PTBD. I can't see anything now. Sandeep, I can't hear you. Your mic is muted.
That's why. Now can you hear me?
Yeah, now I can hear you.
I didn't want to disturb any of the eminent speakers, and that's why I kept myself mute. So now that you want either PTBD is your preference,
Yeah.
but most biliary obstructions because of cholangiocarcinoma come through gastroenterologists. That's the, and that's why we'll sum it up in the end by having a team is so important that which way to go forward. Rajesh, if the patient comes to you, when would you consider an endoscopic drainage, or and which type of stent would you prefer? Rajesh, can you unmute yourself and then speak?
Sandeep, we have taken out the resectable case. The first question prior to that
I'm sorry. I'll just come back to it again. I'm sorry. Yeah, that's the preoperative stenting in cholangiocarcinoma. How do you choose a stent?
So the slides are of unresectable. Can you go back to the previous slides of mine, I think?
So this is your...
No.
Okay, okay.
Yes. So I think Dr. Jagannath has given most of the answer. I would again highlight, because even I'm a gastroenterologist. So first of all, as I again emphasize, it is a multidisciplinary approach. You should always discuss with surgical colleague, intervention radiologist. You talk to the radiologist who has done the MRI, MRCP. You do the reconstruction imaging of the MRI, look at the ductal anatomy. That is very important. And another important thing is, please don't do decompression, especially with an ERCP, before staging. First do the staging and then plan for the biliary decompression if required. Second. So whenever you are planning for the stenting, I think MRCP is mandatory as a roadmap to know, and I think the segmental anatomy has been discussed. Which route to be acquired, PTBD versus ERCP? If you ask me, my personal choice, if patient has to go for the liver resection, yes, I do prefer in type 3A and type 3B as well as type 4. If I have got a local expertise of PTBD is good, I just put an external drainage, no internal external drainage. Small plastic stent may lead to the problem of cholangitis. Even in the ERCP, you do a segmental selective cannulation, but inadvertently die or the air goes to the opposite system, that lead to the cholangitis. So effective drainage can only be achieved if we know the anatomy before going for either PTBD or ERCP. I understand that endoscopic stenting is more physiological, less discomfort, but here we are talking about the preoperative drainage in a resectable case that is for a shorter time. Next. So if you ask me in my center, if patient is operable, then yes, the selective PTBD drainage is good. Second important thing, preoperative stenting is not required in all cases. It only requires if patient has a cholangitis, if patient is a candidate for the left hepatectomy, preoperative drainage generally don't require. If the future remnant volume after post-hepatectomy is less than 30%, you require a portal vein embolization. In that case, you do a preoperative drainage and do the portal vein embolization for the hypertrophy of the rest of the liver segment. If because of any reason, patient requires to do the surgery later, in that case, you can do the preoperative drainage. Lower end block, with a high bilirubin, generally surgeons feel comfortable. If the bilirubin level is more than 15, then I think endoscopic treatment is choice. Or if the patient requires neoadjuvant chemotherapy, preoperative drainage is important. And in my opinion also, I think if the type 3A, type 3B, or type 4 block is there, then PTBD with an external cannula, not PTBD with the internalization is the choice. Putting a plastic stent, the risk of cholangitis is high, and you make the operable case unoperable. So I feel preoperative drainage with the PTBD is the better option, but not in all cases. There are segments of patients who require preoperative drainage. Next. The question comes, route of drainage, I think I've discussed. The only RCT for endoscopic versus percutaneous, in that group, they favor about ERCP, but in my institution, and we prefer the PTBD external drainage will be better. Next. The question of the stenting, the metal stent should not be used. Another important thing, because n number of the time patient comes with the ERCP, metal stenting, you make the resectable case unresectable. Even if you don't have an expertise of interventional radiologist, put a plastic stent. Please don't put the metal stent in the operable case. There are case reports and the case series. The Japanese people prefer the nasobiliary drain before going for the surgery as a biliary decompressive procedure. Next.
Okay, thank you, Rajesh. I think that's the answer which I was expecting from you. We have Dr. Jagannath, who's spoken preference for PTBD and preferably a peripheral PTBD and not the central one, because that probably hampers with the surgical field. I'll come back to Dr. Shivanand once again, intervention radiology. When would you...
Sandeep, if I can do, Rajesh, I love the gastroenterologists who think like surgeons. And you, Chanti Swarup and Mohandas, I mean, you'll think like surgeons, and that's the reason why I think your team is doing extremely good. Very good. Completely agree.
Thank you, Dr. Jagannath, for making it the emphasis on that point that as a physicians, although we see the patient once first, but we should not be uh, bold straight away and say that we will treat you by stenting and that's the end of it, because patient starts feeling better with the jaundice coming down and itching coming down, and they forget that they have to get the primary treatment then. Endoscopic stenting is only palliative. Let me move to come back to Shivanand.
Sir,
Shivanand, are you there?
Yes, sir. You can go for the previous slide.
Okay.
This is question 5.
Okay. I'm sorry. This is question 5. Okay, so I'll bring down back to 4C.
So almost most of the part is covered. I want to highlight only the complication related to.
Yes.
So although next slide, sir.
Okay.
Most of the things are covered by both the speakers. I will not go into a repetition. Only thing I will like to highlight here is that you have to drain the future liver. Don't put a stent in both the livers, both the lobes. So try to drain only the future liver, which is going to be left in the body. The other part, contralateral liver, has to be drained only when there is a cholangitis. Don't drain both the livers simultaneously. Next, sir. And as both the speakers said, the type 3 and type 4 better is PTBD than the endoscopic. That again I want to reiterate. Next. So this is want to highlight the risk which are involved with the PTBD. There are procedure related complications which can happen in less than 10% of the patient, that include bleeding, cholangitis, pancreatitis, and pneumothorax on the right side especially, and the drainage related complication which can, if the patient is kept on tube for a long time, patient may come with occlusion of the catheter, dislocation, leakage, that will add to the morbidity. So that percentage is little very high, that is about 20 to 25%. You have to consider if the patient lands up in these complications, obviously the surgery will be delayed, patient morbidity will be more, and by managing these catheter related problems, there may be a disease progression. The resectable disease may become unresectable. So that is one has to understand. So the tube has to be placed in place for a minimum duration. And there is another thing which is less talked about is the catheter tract seeding. There is one literature I looked at, there is a percentage of 1.5 to 5% developing a catheter tract seeding after the surgery. So within 10 to 13 months after the surgery, the patient may come with a catheter tract seeding at the site of wherever you have put the catheter. So that also keep in mind.
Thank
so
you.
Next, okay, sir.
I think this is the last for this.
Sandeep,
I would like to, may I ask Dr. Shivanand one question, that if the tube is going across the stricture into the duodenum, would you like to internalize it and keep an internal external drain, or would you keep it above the stricture? And what is the preference of the surgeon?
So in our center, we do internalization most of the cases, sir. But having said that, obviously the ascending cholangitis risk is there. But if you keep a catheter only proximally, the patient keep on coming with a slippage. That is one of the drawback when you put an external catheter. So we try to prefer to put it an internal external drainage rather than only the external drainage.
Okay. Thank you.
Can I take 1 minute?
Yes, please.
So I will little bit differ from Dr. Sivanand here, because if the patient is operable, as you do the internalization of the PTBD catheter, the risk of cholangitis is high. Second, PTBD should not be done if the patient is going for the liver transplant. If a patient of cholangiocarcinoma after chemoradiation planning to go for a transplant, in those situations, PTBD is not preferable. Then you should do a plastic stent, careful, map the biliary segment, do the selective cannulation, and then do the drainage of the ductal system. In that scenario, PTBD should be avoided.
So that side, sir, well taken. It is always a multidisciplinary team meeting. You have to take a decision together whether the patient is going for resection, liver transplant, what type of surgery you are. Then only you have to decide what type of device you are going to put and what type of procedure you are going to do it. It is not an individual decision. It is always a combined decision.
I agree, Shivanand. It's a team decision which is important. And once again, we are coming back to the same thing. The theme of the treatment of cholangiocarcinoma is coming to a team effort. And let me go back to Dr. Jagannath once again. Now that we know that a patient is resectable from imaging, how would your treatment change from a hilar versus a non-hilar stricture? And when would you consider a transplant, since that question has been raised?
Okay, let's take you through a resection, approximately 8-hour surgery in next 8 minutes. Next slide. Now, so we do a PTC. We do a PTC drainage, but we might sometimes have to do maybe right anterior and posterior sectors. Every sector has to be drained if the portal vein is patent. So that's important. Second thing is that if there's an atrophy of a lobe, you drain the FLR. That means you drain the liver which you want to leave behind. You don't drain an atrophic lobe like the MRI which I showed you, an atrophic lobe not to be drained. PTC catheters are generally above the block and leave it like that. And maybe we do a cholangio when the system decompresses for a better delineation of the biliary tree. Now, there is some advantage for internal external catheters, as Shivananda said, that these catheters are liable for slipping. So you can get them down, but Rajesh, the thing is, we don't want to get it down into the duodenum. We just want to go and then leave it there so that the ampulla still is functioning. And if there's a cholangitis, you can just open it on this thing. So honestly, the Japanese put it above small fine tubes, but they feed the bile for the patient. And the second thing is about the ENBD. They do a nasobiliary drainage endoscopically and leave the catheters. Unfortunately, for some reason, we are not able to do it because our patients, I don't think, really like to have these nasal tubes and they easily slips off. So once the bilirubin stabilizes, we plan then for a CT volumetry. Next, please. Now, because literally the liver surgeon has to only know about 2 or 3 procedures as far as the hilar cholangio is concerned. He has to look for the right trisegmentectomy, which is the most common surgery done. For that, you need only segment 2 and 3 being left behind. Need to increase the volume of the liver, and that we do once the jaundice subsides by a right portal vein embolization. Once you embolize the right portal vein by coils in this case, you find that the left lobe increases, in this particular case around 34%. Once you have adequate volume, then the patient goes in for surgery. Next. What about laparoscopy? Now, laparoscopy can pick up peritoneal disease. So it has been shown that, but do we use it? When do we use it? Do we use it just before surgery, or do we use it before the portal vein embolization? We have a tendency to use it just before surgery, knowing fully well that some patients who have undergone portal embolization are not going to be resectable because of progression. So that's what we do for laparoscopy, but it's only peritoneal disease. It can't be anything else. Next, it can't pick up anything else. Now, the surgical steps, I'll quickly go through and also go through. It's going to be radical surgery. This entire extrahepatic biliary ductal system, the bile duct ligated just above the pancreas and then going up completely, and ductal margin should be negative. Next. Lymphadenectomy is definitely there. We clear entire portal lymph nodes going on to the hepatic artery and right up to the common hepatic artery and posterior pancreatic lymph nodes. Lymph node involvement does not mean patient is not resectable. So lymph node can be resected along with the disease, even if they're involved. So that is something which we routinely do. Next. The liver resection is certainly almost necessary. Earlier on, when we used to do a subhepatic hilar resection, patients came back with recurrence. So liver resection, the commonest surgery is right trisegmentectomy. That means the entire right lobe, and including segment 4. Is the right trisegmentectomy, and the left lateral segment is preserved for with the PTPE. The left resections are a lot more complex, which are reserved for some patients with a left portal vein and arterial involvement. Next. Next, please. Now, once you open, this I have to, as a surgeon, I have to show you some surgical slides. Otherwise, you will not be impressed. So, first thing is, see, there's no peritoneal disease, even if you've done a laparoscopy. Intraoperative ultrasound is an important tool. We have to see the intraoperative ultrasound and again reconfirm your anatomy. And that's a nice surgical thing which you must have seen surgeons showing you, just to show off their skills. A portal vein, the left branch of portal vein, the left hepatic artery taking off directly, and the bile duct, and then the whole thing is lifted up. Very important. Please do understand one thing. The surgery is determined before we open the patient. Once you ligate the lower end of the bile duct, you are committing for resection. So be sure of what you're doing, because once you commit, no going back. And then there's no going back. Next. And that's once you ligate the portal vein, you get a nice line of demarcation. So this is the only liver which is going to be left behind. Then you take the right hepatic vein behind. That's the outflow, inflow, both are dissected. Next. Then you split the liver, whichever way you want, you can split the liver. Caudate lobe is mandatory to be resected, whether it is right lobe or left lobe, because that's a bed of the hilar cholangiocarcinoma, unlike any other hepatectomy. Next. And then finally end up with the bile duct resection is the last one, and then you start doing a Roux-en-Y anastomosis. So that's about 8.5 hours surgery. Now there are some shifts in the management. Selective biliary drainage. Rajesh said that if there is no cholangitis, if there's a left lobe atrophy, and if it's adequate FLR, there is no need for going on for biliary drainage. You can straight away go in for resection. I talked about this endoscopic nasobiliary drainage. I'm not very sure how many centers do it. I like to find out that. Yes, there is a risk of tract sealing, but the discomfort for the patient for a nasal catheter is significant. I'm not sure it will work or not. So that's where we stand. So we do PTBD, PTC drainage, and then proceed. Now, this is what I wanted to clearly remember. The same thing which I showed you earlier. Left lobe atrophy, left portal vein blockage, a good right lobe. That means this patient had an autoembolization and hypertrophy of the right lobe. You can go with the surgery without any drainage. Next. You want me to talk about results of surgery now or a little later?
Please go ahead. Please go ahead. I think that's important.
Okay, fine. We have done all this surgery, but what's happening to the patient? Slide, please. See, this is a localized sclerosing tumor mostly. So it's not something which is like a pancreatic adenocarcinoma, fulminant spread. So if you really resect with an R0 resection, look at the survival. This is something substantial. Even with a microscopic margin positive, you have a 2-year survival. And if you locally advanced, still they're alive. That's the reason why you need to have a good palliation for this patient. So, and how do you ensure R0 resection is by an accurate staging of everything which I told you. But unfortunately, resectability is largely dependent on the surgeon. A surgeon can have a very low resectability, or it can have very high resectability like Nagino and Nimura in Japan. But that the centers which are doing exclusive hilar cholangiocarcinoma work get the best results with a margin negative resections. Next. So many series, largely Japanese, Memorial and other series have all got good resection, good numbers. All are hepatectomies, all have fairly good survival. That's important. And what about prognostic factors are R0 resection and nodal disease. What about intraoperative frozen section? We have stopped doing intraoperative frozen section because it's very fallacious. It can be negative on frozen, positive on the paraffin. Fundamentally, the surgeon has to get a 5 millimeter plus margin, and he has to have a negative tumor-free margin. If he has planned well, he'll get a negative margin. That's why the shift is towards a extended resection, like a right trisegmentectomy and not a right hepatectomy, and a left trisegmentectomy and not a left hepatectomy, because you can get a better ductal margins. Next.
I think that's the last of your slides in this section, so thank you.
Right.
Thank you for elaborating the results and the types of surgery that has to be done. So far we have learned that when a patient comes, we have to stage them, try to get the tissue diagnosis if possible. If patient looks to be operable, put a plastic stent or a PTBD. The latter is preferred by the surgeons. But what about and then subject taking for surgery later on. But what about the patients, a large chunk of the patients of cholangiocarcinoma who are not fit for surgery? So how do we approach those patients? So may I call upon once again Rajesh to tell us about, may I get your slides back? This is 5.
Am I audible there?
Yes, Rajesh, just a minute.
So, yeah, Sandeep and the dear esteemed panelists, now here I will take the U-turn. I will not send my patient to the interventional radiologist except type 4 block. As an aggressive endoscopist, can you put my slides? As an aggressive endoscopist, unresectable case, lower end, no question, just put a metal stent. I don't prefer to put the plastic stent. Mid, I will go for, so again, I will do an MRCP as a roadmap. This is very important, highlighted by Dr. Jagannath, because MRCP images are webbed. You should not see in one plane. Try to look for the images, find out how many numbers of the patient require. I will give pre-procedural antibiotic, lowered mid-end, Hyler 1 and 2, no confusion ERCP. The debate come between type 3 and type 4. Type 4 patient come, that is 20% of patient in my practice. I refuse to do ERCP. Type 4 block, I send the patient to my interventional radiology colleague. When come to type 3 and B, then depending upon the liver parenchyma, atrophic segment, I decide how many numbers of the patient require. And in this scenario, I suggest my gastroenterologist colleague, please don't put the plastic stent. Try to use the uncovered metal stent. Now, earlier people talk about the unilateral drainage, bilateral drainage. I think the newer concept is of a complete versus incomplete drainage. And I think if you do a complete drainage, then it improves the survival, less risk of cholangitis, less morbidity, and less number of intervention, less number of patients after ERCP requires the PTPT, because many of the time you do the unilateral stenting, after a few days, the patient land up into the cholangitis. As metal stent has been placed, then this patient required PTPT. So my concept is of complete drainage, uncovered metal stent, and I am very aggressive endoscopist, type 1 chiral block, type 2, 3, and 3B. I prefer to do ERCP type 4. I send the patient to the interventional radiology. Next slide. So we talk about the type of stent. I think the data favors about the metal stents. It has a longer patency, better palliation, less risk of cholangitis, and the survival advantages are also there. Next slide. When we again talk about the biliary stenting, the choice of stent SAMs, longer patency compared with the plastic stent, only uncovered SAMs. Please don't put the covered SAMs in these patients because you are blocking the contralateral side of the biliary radical. Patient land up into the cholangitis. Plastic stent should be avoided. Now, this is very important. Next 3 slides. Our preference in the last 10 years is to use the air cholangiogram. But if somebody is using the dye, and if you have opacified both the lobe, please try to drain both the lobes. Otherwise, the risk of cholangitis is there. If you are not able to if you are able to opacify both the lobes and you are not able to drain, then after draining one lobe, ask your radiological colleague to intervene and drain the next lobe, because the survival is better. If you have opacified one lobe, you drain it, it is better, especially in the type 2 block, that is preferable. The worst scenario is if you have opacified both the lobes and you drained one, the patient has a poor survival. It's always important. Always look for the MRCP, look for the liver CT scan, look for the viable liver parenchyma, and then intervene. Do a selective chlorination of intrahepatic ducts and put the uncovered metal stent. Next. Now the question was already discussed by everyone. Please don't try to drain the atrophic lobe. You may be fascinated by the dilated duct in the atrophic lobe, but these are not dilated duct. Because of the atrophy of the lobe, these ducts appear. Now this is the next slide. The important paper is because we always talk about the dilated ducts, but this is a very valid study, and where they count on the basis of CT scan the amount of liver parenchyma to be drained. If you drain more than 50% of the liver parenchyma, I think the median survival is better. If you drain more than 50% of the liver parenchyma, you can do on the basis of CT scan. Next. When you do the multiple stent, will it be side to side or stent in stent? So stent in stent is more preferable in the ACR, but in my clinical practice, I always do side by side. So it is always important you enter the guide wire into the 2 radicals or 3 radicals. If you're planning to do the bilateral stenting, then put a 6 French stent or dilate the stricture with 6 millimeter hurricane balloon, because putting the sequential stenting will be difficult. Now, if you look the comparison between stent in stent, that is a Y stent, which is the most commonly used by the Koreans or Japanese, versus side by side stent. When you do the stent by stent, then the re-interventions are more easy. in comparison to the Y stent or a stand-in stent. So I always prefer to put the stent by stent. And another important thing is if you can take out the proximal margin outside the papilla, the reintervention will be easy. Otherwise, as the bile duct is not dilated, in that case, one of the stent is compressed, and in that segment, it is difficult to do the reintervention. As I said, nowadays the concept of a complete drainage, I think that is very important. Doing the incomplete drainage, if you look at here, in all the cases, this is incomplete drainage. Either you put the one stent or the two stent. Next. Next. So this is the concept of complete drainage. You look at the MRCP. If you have taken the cholangiography, put your guide wire into the right anterior, right posterior, and the left ductal system, and try to place the stent in all three. Yes, plastic versus metal, preferably uncovered metal is better. But if you are unable to put it, then the plastic stent is also a viable option. Next. So the management of the biliary obstruction, I still feel, is a multidisciplinary where you discuss as a team and decide which is the best modality of the patients. Depends upon the expertise when you try to drain the biliary segment, either through the PTBD route or through the ERCP route. But yes, through the PTBD route, I prefer to do in the single setting rather than keeping the tubes outside. So in conclusion, the understand the anatomy by doing the pre-procedural MRCP, look at the volume of the liver to be drained by the CT scan. Palliative drainage should always be done with the same. Plastic stent should be avoided. Do not drain the atrophic liver segment, and drain at least more than 50% of the liver parenchyma, and multidisciplinary approach is ideal in patient of myeloid block.
Thank you, Rajesh. Uh, that was a nice presentation of how to approach in a patient with unresectable cancer. But not everybody, as you said, is amenable to endoscopic. It may be type 4 or type 3 advanced, or sometimes even the ERCP is not possible. So what is the role of intervention radiology in patients who are unresectable cholangiocarcinoma? Also, I would like, Shivanan, can you speak on, tell us about on portal vein embolization and any role of local ablation? Shivanan, please.
Sir, already the unresectable disease has been covered more or less. It is well, but I would like to talk about the portal vein embolization. It is mainly done to prevent the post-operative liver failure after the right hepatectomy. So it is indicated whenever there is a future liver remnant is less than 25%, where the background liver is normal with a normal LFT. If the background liver is having a compromised liver function test, then the future liver should be at least 40%. So the approach is either we can go for the ipsilateral side, where the part of the liver which has to be removed, or the contralateral method. Hypertrophy usually happens within 2 to 4 weeks. So this is the contralateral side, and this is the ipsilateral side. Next slide. Next. So this is an example where we have gone to the left contralateral side. Previous one, sir.
Yeah, sorry.
The contralateral side, it carries the risk that you may damage the future liver portal vein. So that is one of the risks, but it is more anatomical, more easier technically, but it carries a risk. Next slide. So this is a ipsilateral. It is technically challenging, but it is much safer. You can prevent the portal vein thrombosis of the contralateral side. So this is the ipsilateral portal vein thrombosis embolization. Next slide, sir. So these are the advantages which I have already highlighted. Next. So various embolizing agents are used. The best embolizing agent right now, more economical, cost effective, is the glue, followed by PVA particles. So these are the two widely used embolizing agents, but cost effective is the glue. Next. So what we do is that before the embolization, we measure the volume, do the volumetry. If the future liver is measures less than 25%, then patient is subjected to portal embolization. After the embolization, the CT volumetry is again done at 2 to 3 weeks to look for the hypertrophy. If it measures more than 25%, or else if it is measures more than 10% of the previous value, that is sufficient. Next, sir. So this is already been covered. I would like to go for the RF local ablation, sir. Next. Next. Okay, this is the mainly we don't have any role to play in the unresectable hilar cholangio. So there are local ablative therapies for the intrahepatic cholangiocarcinoma, where people have used RFA, radioembolization, high dose brachytherapy with a variable results. But this is mainly to control the local disease per se, nothing else. Next, sir. Next.
Yeah.
So the next one. So this is an example of an intrahepatic cholangiocarcinoma. We did a radioembolization. So even after embolization, after 3 months of therapy, next, sir.
I think, yeah.
Okay, there is no response. So these tumors are very, very radio insensitive, chemo insensitive. Only RFA may play a role to local control the disease. That's it. They don't radioembolization or chemoembolization. They don't have any role. Thank you, sir.
Thank you, Shivanand. So now we've understood that if unresectable, we can do many things, but it only prolongs the survival to some extent, and also the quality of life. Dr. Jagannath, you told us about patients who are operable or resectable with R0 resection. They live for 4 years, and those who have R1 resection about 2 years. What about the patients who do not undergo anything at all, who are unresectable right from the beginning?
This possibly has to be addressed to the whole panel, because see, these tumors are localized. So it's not as though that there is going to be a short survival of 4 to 6 months time. But what we have seen, I see Rajesh is doing a great job in getting the entire biliary system drained, but that is not the normal thing. You know, you have just one stent, and then they come into a repeated cholangitis. I think a couple of points very important: not covered stents and the side-by-side stents are all very, very, very good points. But they come with repeated stent blockage and changes. If you put the stent from the top, you have a big issue that if you are going to push the stent into the, and then how do you change that stent if it gets blocked? So they come with multiple cholangitis, stent blockages, and metal stents are difficult to change if they're from the top. So, and then slowly, it's a slow progression. It's actually a very unfortunate situation of progression to liver failure. See, though there are many other, RF and other things, the fundamental, the only issue which these people have is adequate biliary drainage. And if you provide that by any good method, for a longer period of time, their quality of life is better. And if you don't do that, then it's really a miserable way ahead. So I think next slide.
I think this was the one slide which I wanted you to speak on, because you spoke on the resectable part. The unresectable, how is their survival benefit and the quality of life ahead?
But these people keep going to, I think, the surgeons, the gastroenterologists, IR, and then, it's really a tough thing to handle. And yeah, they have multiple episodes of sepsis and progress to liver failure.
At this time also, I think it may be a good idea to get the multiple team together. In the beginning, they have gone through the team. At one point, they had an operation, and then they should come back again to the team. And so that instead of patient going to 3 different persons, a surgeon, a physician, and the intervention radiologist, if all 3 can be together, and then explain to him that what is the likely course ahead for him, that will probably reassure him and understand his disease pattern.
Yeah, you're right, Sandeep, because normally our tendency is that, oh, no, it's not my job anymore. Surgeon says, go and meet so-and-so, go and meet so-and-so. So they get shunted from place to place, which should not happen. You're right. We should take care of them even if we don't talk to them.
Yes. Yeah. At this point of time, let me introduce you to an important person who is part of the team, who has not spoken so far. May I call upon Dr. Ramaswamy, the oncologist, and I would like to ask him a few of the questions is, what is the role of chemotherapy or radiotherapy, or chemotherapy first? Is the efficacy in cholangiocarcinoma? Does it provide any survival benefit? When would you like to give chemotherapy, pre-operatively or post-operatively? Is it pattern similar to cancer of pancreas? And when would you consider an onco treatment in a doubtful diagnosis? Because often we don't have a tissue diagnosis and patient operates to be inoperable. Would you like to give a chemotherapy or not? Can you comment on those things? I will just share your slides, Ramaswamy, in a minute. I'm sorry that you came a little late in this discussion, but that's equally important. We wanted to have the flow as we normally progress. Ramaswamy.
Yeah, so at the outset, I'd like to thank Dr. Govind and the entire team for calling me to this nice session. As always, it was a pleasure to listen to Dr. Jagannath and the entire team. So next slide, please. So the learning points that I'd like everyone to take home at the end of this 10-minute session is molecular classification, systemic therapy in advanced disease, systemic treatment in resected disease, and a little bit on how radiotherapy works. Next slide, please. Cholangiocarcinomas are not only anatomically different, they're also molecularly different. And this is now known over the last 4 to 5 years. I've now compared the intrahepatic and extrahepatic cholangiocarcinomas with gallbladder cancers, which are far more common in India. And you can see that besides TP53, there is a marked variation in the molecular profile of these tumors. As you can see, in intrahepatic cholangiocarcinomas, the IDH and the FGFR mutants are markedly more as compared to the other subtypes. And this is important. Next slide, please. Specifically with regard to intrahepatic cholangiocarcinomas, we have a number of potential targets for treatment. This includes FGFR, IDH, HER2, and MMR. We don't have drugs for all of them, but for some of them. Next slide, please. It is also known that despite all the local treatments available, approximately 60 to 70% present with unresectable disease, and even approximately 25% of cholangiocarcinomas which appear resectable after a proper workup on exploration are unresectable. So in such a scenario, what are our goals of management? And that is where the MDT comes in. You need to explain that your symptoms are going to come down and we are going to try and palliate. We're going to try and improve quality of life and improve survival. Those are our goals of management. Next slide, please. A lot of times we talk about survivals without looking at whether patient-related outcomes actually improve. Now, this is data from 2.5 decades ago. And there it was clearly seen that chemotherapy improves patient-related outcomes as compared to supportive care alone. This is patient function, which is labeled as PF, and fatigue. It delays the onset of fatigue as well as maintains physical function for longer than doing nothing at all. Next slide, please. Over the last decade, the standard treatment for unresectable and metastatic biliary tract cancers, of which cholangiocarcinomas are predominant in the West, is gemcitabine plus cisplatin. This has not changed over the last 1 decade. The survival is around 1 year. Closer home, next slide please. Next slide please. Yeah, closer home, previous one, sorry. Closer home, a lot of Indian oncologists prefer the gemcitabine plus oxaliplatin regimen. It has not been seen in cholangiocarcinomas, but this is data from Dr. Atul Sharma's study from AIIMS, where he showed that gemcitabine plus oxaliplatin is also a good regimen to use. Next slide, please. Now, a majority of cholangiocarcinomas are not metastatic in the sense they don't have distant disease, but have locally unresectable disease. So in this scenario, while the standard remains chemotherapy, is there any benefit of adding radiation? We don't have the answer yet, but there is a trial at Tata Memorial which is addressing this particular question, and we will have the results in maybe 2 to 3 years. Next slide, please. Besides gemcitabine, oxaliplatin, and gemcitabine cisplatin, there are other regimens that are available, but these are the 2 most common regimens. However, approximately after 6 to 8 months of first-line treatment, majority of patients will have progressive disease. And then what do? There are not many options. You could enroll them in a clinical trial. You could try regimens such as FOLFOX or irinotecan. And now for cholangiocarcinomas, we have targeted therapy as well. Next slide, please. So this is recently published data of patients who had FGFR rearrangements. A drug called pemigatinib now is FDA approved in second-line treatment. And the median overall survival with this drug in the second line, though not mature, was around 21 months. Next slide, please. The other mutation that has been targetable in cholangiocarcinomas is the IDH1 mutation. There is a drug for that as well. It's called ivosidenib, though the benefits are marginal. Next slide, please. Now, when we talk about post-resection, the endoscopists and the surgeons have drained the tumor, have operated. What next? Here, the goals of treatment are different. You want to improve survival. You want to address micrometastatic disease. Very rarely in cholangiocarcinomas, you want to give therapy before resection to decrease the chances of R+ resections, which have poor outcomes and increase resectability. Next slide. So till 2010, 2012, because of the lack of data, there was no great benefit of giving adjuvant therapy. So this meta-analysis done in 2012 showed that if at all you had to give something post-resection, it would be best to give it in patients who have lymph node positivity or had an R+ resection. Next slide. But over the last 2 years, we've had more data on this particular aspect. This is a study which was published in the Lancet, where post-resection in cholangiocarcinomas, they observed or gave capecitabine alone. Now, the difference in survival was 15 months. It did not achieve statistical significance. Next slide, please. But on a per protocol analysis, the difference in survival was 17 months. That is almost 1.5 years, and which is why a majority of centers have now started using oral capecitabine post-resection. Next slide, please. This is another study which looked at gemcitabine oxaliplatin. This was a negative study. So as of date, gemcitabine oxaliplatin should not be used post-resection of cholangiocarcinomas. Next slide, please. The take-home for adjuvant therapy or systemic therapy post-resected disease is that a number of centers are now using capecitabine. Most will consider some treatment in case of node positive and margin positive disease. However, in earlier stage cholangiocarcinomas, treatment is not uniform. In PMH post-resection, we use gemcitabine and cisplatin. Next slide, please.
Thank you, Ramaswamy. That was the end of your talk on the question raised of chemotherapy. I would also now like you to answer, what is the role of radiotherapy? Any role of intraductal brachytherapy? And what's your take on that?
Yeah, sure. So radiotherapy, usually we consider 4 different modalities of treatment, whether it's external beam, brachy, SBRT, and now we have some data for proton as well. Next slide, please. The problem with radiotherapy is that there is not enough prospective data, which is why we do use RT, but there's not enough evidence prospectively to use or not to use. One area, previous slide, please. Yeah, one area where there are very good outcomes with using neoadjuvant radiation and chemo is in hyalocholangiocarcinomas, where a combination of pre-op treatment and transplant was shown to be slightly better than resection alone. This was not a randomized study, but this is one of the largest series for hyalocholangiocarcinomas of almost 150 patients. Next slide, please. When it comes to intrahepatic cholangiocarcinomas which are not resectable, again, there is retrospective data for radiotherapy, and with good EBRT, you can have survivals of 1.5 to 2 years in unresectable disease. Next slide, please. SBRT, next slide, please. Next slide. Yeah. So SBRT has emerged as a technique over the last decade. The importance of SBRT is that it's very conformal and it avoids toxicity to adjoining organs. And this is especially important in cholangiocarcinomas, where it is your dosages have to go to structures like liver, duodenum, and stomach. Encouraging data is there where you can have survivals of almost 2 years in unresectable cholangiocarcinomas. Next slide, please. To summarize, I think just as cholangiocarcinomas are not anatomically similar, they are not molecularly similar. The standard is systemic chemo in advanced cholangiocarcinoma, and there's an emerging role for targeted treatment. In unresectable but non-metastatic cholangiocarcinoma, concurrent chemoradiation is an option. In node positive or R plus resections, you will consider adjuvant chemotherapy, and there is limited prospective data for radiotherapy, but SBRT is an exciting option. Thank you.
Thank you, Ramaswamy. Let me ask you one question. You told about these molecular markers. You know, the tissue acquisition is generally very difficult in cholangiocarcinomas. You need to have the tumor tissue to find out these markers. How easily it's available in India, and in the paucity of the sufficient tissue, how do we proceed?
So I completely agree with you on that, specifically with regard to the hilar cholangiocarcinomas. I think 30 to 40% of the time we are unable to get tissue. But when it comes to the EHCCs, I mean the distal cholangios and the intrahepatic, in our institute we are trying more and more to get this tissue. It may not help in the initial management, but definitely later in the management, once these drugs come into the market, it will be useful. But with regard to hilar cholangiocarcinoma, yes, often we treat without a tissue diagnosis.
Thank you very much for answering that. We are coming to the end of the discussion. We have short up time by a little over a few minutes more. May I ask Rajesh one last important pertinent question of palliative endoscopic therapies? What's your take on that? You heard of RCA and PDT?
Yeah, Sandeep, I think I'm going to talk about the literature because I don't have a personal experience and you are the master for this. So I think you can give feedback. But as Dr. Jagannath says, and this is the most important problem, patients who are inoperable, they have been on the stent either by percutaneous route or by endoscopic route. The problem is of the stent blockage, extension of the disease to the secondary and tertiary biliary radical, a repeated episode of cholangitis. So how to solve that? And I think there are some literature available doing the photodynamic therapy or biliary RFA, improve the quality of life by increasing the patency of stent. Next. So when we talk about the biliary RFA, this is a Habib probe, which is 8 French, 180 centimeter in length, single use, but you can use multiple times. I have an experience of 4 or 5 patients only. It is go over the wire, 2 8mm stainless steel electrodes, and it give the ablation area of 2.5 centimeter. You give the typical voltage of 10 watts for 90 seconds. It produces a coagulative necrosis. Sandeep, you can add because this is the machine which generate the ablation and give the tumor necrosis and improve the stent patency. Next. So if you look at the literature about this, yes, case reports, case series, systemic review and meta-analysis is available. And all these papers shows, next, that if you do the biliary RFA, in those scenarios, it increases the survival by a few days, stent patency is improved, but it is associated with the adverse event in the form of cholangitis, cholecystitis, or sometimes acute pancreatitis if you are doing for the lower end. The important thing is, whenever you are planning for the biliary RFA, patient should not be on the stent, or if the patient is on the stent, then he should be on the uncovered metal stent. And if the stent can get blocked, then you can do the intra-stenting metal stent, you can do the biliary RFA to open up the block stent by the tumor. Next. PDT, this I'm talking about the literature. I have no experience. Photoferrin, which is injected, and it has a preferential affinity for the neoplastic tissue. It accumulated, and you give the patient should be given the photosensitive, that is light therapy, after 48 hours of injecting the fluorescent agent, that is photoformer, and it has the effective depth of 4 millimeter. it is associated with the side effect in the form of cutaneous hyposensitivity because when you inject the photosensitive agent. So this is the meta-analysis of photodynamic therapy, and that shows the stent patency. When you do the survival in stand-alone patient or patient who underwent stenting with the photodynamic therapy, if you look at the survival was 413 days in comparison to 183 where the photodynamic therapy was not done, and the side effects are self-limited in terms of photosensitivity. Next, when you compare the RFA versus photodynamic therapy for the local stenting, the two study which I come across in the literature, and both study shows the biliary RFA and the photodynamic therapy has equal, there is no difference in the survival, there is no difference major in the stent occlusion rate. So I think it will depend upon the available modalities in your, but I think this is very important question. And one thing come in my mind, although literature is not available, if you have a drug-eluting stent, that might help the blockage because either because of the tumor in growth or the overgrowth, the stent get blocked. Another important thing, many of the time it is not because the tumor in growth, because there is an angulation in the left ductal system and the angulation is more than 50 degree. In those scenarios, there is a local sludge formation. You just do the ballooning and the stent occlusion improve. But if there is a tumor in growth or overgrowth, in those scenarios, either you do a percutaneous or endoscopic, but by doing the photodynamic therapy or the biliary RFA, for photodynamic therapy, you don't have to do the metal stent, you have to put the patient in the plastic stent. But for the biliary RFA, you do the biliary RFA followed by the metal stent or the plastic stent, depending on the availability of the stent. And that help in improvement of the stent patency, and that give the improve the quality of life, because the major problem in these patients is recurrent cholangitis because of the stent blockage. Thank you for the patience. Sandeep, you can highlight if you have any comment.
Thank you, Rajesh. I think for RFA, it is better to do before a stent is placed. Doing an RFA after placing a metal stent actually adds more problem. There can be short circuiting, and which can cause sometimes the RFA is not delivered to the area that we want to. Thank you very much. I think we have almost come to the end of this discussion, 1.5 hours of, but the last few slides is, may I request Dr. Jagannath on what should be the pathway that when a person comes to a group of doctors who are dealing with cholangiocarcinoma. This is a slide made by you, and very rightly so. In one slide, you summarize. Can you just elaborate on that, please?
One thing is, I'm so happy that all the panelists have agreed on the same pathway. So that's very, very good. So normally the patient gets an ultrasound and maybe a Doppler to give a little more information on the vessels. Then MRCP is one investigation which is normally done, but a triphasic CT is what you need. And then differentiate as map it, a type 1 and 2 resectable. You can do an drainage, maybe endoscopy. And type 3 can be selective PTBD, ENBD, as I said you with a query for India, do a volumetry and PVE, and then going for resectability, hepatectomy. Unresectable will go in for palliation with a metal stent, which can be elegantly done by Rajesh from below. But the fundamental principle is drainage of all the sectors of the liver. So this is a message. A multidisciplinary team, drainage of all the sectors are critical for these patients, both for palliation. So this I would put as the last one. The team approach is the most essential thing. And then though the tumor, it's a slow growing tumor and dissected by most of the good HPB centers, early referral to a center which contains all the elements as we discussed on this panel are important. And each member of the team is extremely important. If you don't have one good member, then your center will fail. So I think it's a complementary effort by the entire team, and that will give the best results for these tumors and worthwhile treating them in such centers.
Thank you very much, Dr. Jagannath, for these wise terms in the very end. May I request any questions or comments from Dr. Saraswat or Govind before we actually end up winding up? We had questions in between which we tried to answer so that there's nothing left for the end.
Well, I think, Sandeep, I must compliment you on orchestrating one of the finest panel discussions I've heard on cholangiocarcinoma. Um, I think we just heard what Dr. Jagannath had to say about the team, and Govind can certainly take the credit for putting together the ACE team for cholangiocarcinoma management on this panel discussion. When obviously, although the discussion, we've spent a good 1 hour 40 minutes, or about 1 hour, 1.5 hours going over the ramifications and the complexities. I think a very comprehensive and a thorough assessment of all areas of cholangiocarcinoma has been done in this. And I think the final quote from Phil Jackson that's on your screens is probably the most apt summing up of this afternoon's panel discussion. I think just at the risk of taking some more time, one question that's always bothered me, and I'd like to put it to the panel, is I think roughly 20 to 30, about 20-25% of patients with hilar blocks come to us with a history of prior cholecystectomy. So if a patient has had a cholecystectomy in the previous 2.5 years or so, and now comes with a hilar block, how are sure are we that it's a cholangiocarcinoma and not a recurrent missed gallbladder cancer? And how do we proceed to differentiate between these possibilities? But probably the molecular approach, the radiotherapy and chemotherapy approaches might be different in the situations.
Rajesh and Dr. Jagannath, would you like to take that?
See, that's coming from the region which gallbladder cancer is quite rampant in the northern UP and all that. It's a relevant question. See, one is that we review the histology and see the time interval between the cholecystectomy and the hilar block. If it's like, say, 2 years, it's a pretty long time. Even then, it has to be considered. Pointers toward the gallbladder lesion are a mass lesion in the liver, particularly segment 4. If there's a mass lesion, it is more likely to be a gallbladder cancer. Now, can gallbladder cancer, which is localized, be treated like a hilar cholangiocarcinoma? The answer to that is yes. If someone has, after 2 years, has a localized hilar block, no other disease elsewhere, it's still worth treating them as far as the hilar block is concerned. So give them a chance. On the other hand, a gallbladder coming with an obstructive jaundice per primum is a bad disease. So that is something which is difficult to handle, and certainly largely outside the curative resections.
I ask you one question, Dr. Jagannath. When we have these patients with hilar masses, hilar stricture with no obvious mass and tissue can be obtained by EUS, are you worried about peritoneal spread which can happen because of EUS acquisition, or you would like to operate without a tissue?
Both, I would say that both. I don't want to needle that tumor which is localized. And second thing is, even if it is positive or negative, I'm going to go in for surgery, and with even a possibility of a negative histology. So I'm fine. So I don't insist on a US guided FNA. The US, if at all is necessary, is going to be useful for staging. For example, if you have a node in the celiac region and you want to show it's metastatic or non-metastatic, that's when you do an FNA. If it is metastatic, obviously these patients would not go in for surgery. That is the use of US.
So nodes away from the primary area of
away.
interest would be
well away.
targeted, and rest can be left like that.
Yeah.
Can I intervene?
Stop sharing your screen. Sandeep, can you stop sharing your screen?
Can I intervene in this?
Yeah, please go ahead, Rajesh, have your say.
So as Dr. Jagannath says, if the patient is operable, you don't require a green. But if the patient is due for the liver transplantation, you have to require a tissue diagnosis, you have to give the chemoradiotherapy, and patient will be subjected to the surgery. The question Sandeep has asked very valid about the transperitoneal seedling. So when we talk about the drainage to the PTBD to decrease the bilirubin level, there is also a risk of peritoneal seeding, which has not been taken as a contraindication. Number second, the paper which has been published in HPB, where the 191 patient was supposed to go for a liver transplant, and they underwent transperitoneal FNA, and out of 16 patients only, 16 patient, 6 patients was positive for adenocarcinoma, and out of 16 patients, 8 patients goes percutaneous and 7 patients goes EUS guided. So out of 6 patients, 5 patients develop the peritoneal seedling. Only on that paper, the EUS has been accounted as contraindicated for taking the FNA. I think this area needs to be taken. We require more data to say, while taking EUS guided FNA in the hilar mass, is it really a risk of peritoneal metastasis there or not? Because if you read the literature, and my esteemed colleague has also talked about when you do the PTBD in resectable case, the risk of tumor
Right.
seedling is there.
Dr. Puri, I think we have now reached 1:45. So one of the longest master classes that we have had. I think there's still a lot of unanswered questions. There are a lot of questions that have come into us from our audience, which we have not been able to take up because the panel discussion itself was so exhaustive. So I'll request Professor Makharia and the Secretariat team to mail these to Dr. Sandeep so that he can coordinate and get us the answers, which can then be mailed back to the questioners or put up on our website. And I think with this, I think we need to, all good things need to come to an end, and this discussion. I'll request Dr. Govind to please do the closing honors as well.
Thank you so very much. I think this has been a wonderful, wonderful exposition of questions which are relevant in treating cholangiocarcinoma. I mean, this is it has been a treat to listen to all the experts and their real experience and their very wisely suggestions. Thank you in particular to each one of the moderator and panelists, Dr. Sandeep, Dr. Jagannath, Dr. Puri, Dr. Anand, and Dr. Sivanand. It had been a masterly masterclass on cholangiocarcinoma. I think the point which was highlighted that think before you do, and last time was we had another speaker masterclass that cholangiocarcinoma is a condition where you first plan and then do, rather than do and then plan what to do. And I think we should remember that. And this was the focus on the cancer series on masterclass, that to decrease the gap between different experts so the patient gets a wholesome care, what is a typical multidisciplinary care by the whole team. With this, we come to the end of this session. Again, thank you all the viewers. We have been taking your lunch time, that too on Sunday. Our apology from whole team that we overshooted a time beyond any bounds, almost reaching 1 hour 45 minutes. But just before we close, let me invite you for the next session next week. That's on September 20th. That we again one of the masterclass on multidisciplinary treatment of carcinoma pancreas. And this will be we'll announce all the panelists on the email. And we also want to do quick things that there are only last 2 days left for abstract submission for ISG. Please do submit your abstracts and papers for young investigators and planning sessions by September 15. And we're also announcing ISG elections tomorrow. With this, we want to thank the Lupin Pharmaceuticals who supported this masterclass. Thank you, Lupin, for supporting once again the masterclass. And with this, we say bye-bye to everyone and have a nice Sunday. And we'll see you on September 20th for the next masterclass.
Thank you all. Enjoyed it. Thank you all. Thank you very much.
Thank you, Yogita, and thank you, Dinesh, for technical support. Okay, bye-bye.